Well, we're on the hour here, so we can go ahead and get started. Good morning, everyone. It's my pleasure to introduce our speaker today, who often needs no introduction, as he's well known throughout the Mountain West AETC community. Dr. Brian Wood will be speaking with us today. He's Associate Professor of Medicine at the University of Washington and also the Medical Director of the Mountain West AETC HIV ECHO program, where he often communicates with many of you on the talk today about a variety of cases and offers his great expertise. So it's my pleasure to introduce him to talk about 2020 HIV treatment update, what's new and what's coming soon.
Thanks very much, Tricia. Thanks to everyone who helps organize these, and it's an honor to be invited back, and I'm looking forward to this. I'm going to be reviewing some of the recent updates and guidelines and antiretroviral approvals and some of the things that have changed and been controversial or hot topics over the last year, focusing on adult HIV treatment. I should be clear about that. And I'm going to talk about some things that are coming, likely coming soon, including the first ever long-acting injectable antiretrovirals, which is exciting, but still has a lot of unanswered questions around it. So get ready for some polls. I would like to hear from you, and we're going to cover a lot of ground. Thank you very much to colleagues who have donated some slides, Dr. Budak, Dr. Hatchie, Dr. Spock. I will be discussing investigational antiretrovirals. I want to be clear that I do not have any financial interest in anything I'm going to talk to you about. I think that's extra important today because I am going to be sharing some opinions about antiretroviral agents, but I have no conflicts of interest. So these are the three topics. First, the fairly recent updates to recommendations for initial ART and updated data for antiretroviral safety during conception and pregnancy, certainly a hot topic over the last couple of years. And then one of the most controversial areas of HIV medicine right now, how do we optimize an individual's long-term health in terms of weight, cardiovascular, and metabolic risk? And should we or should we not be switching antiretrovirals because of weight change? Hugely controversial, and would like to hear your opinions as we get there. And then at the end, some of the latest approvals for salvage therapy. A few resources for you: the National HIV Curriculum, the Department of Health and Human Service guidelines. Please note that guidelines website has changed. Note there the current updated link, and the IAS-USA guidelines, which were recently updated and published. But let me do this. Let me share a real case, someone I met 6 months ago or so, and let me ask you your opinion on initial antiretroviral therapy for this individual, which will lead us into a discussion of the most recent guidelines on starting ART. So this is a 30-year-old Latina woman referred after new HIV diagnosis. She had presented to a primary care provider requesting a test. She thought she had risk based on a prior sexual partner. Her test was positive, her screening test was positive, her baseline CD4 count was 447, HIV RNA or viral load 13,700, genotype sent and pending at the time that you see her. She presents to her first visit with her current male partner. They use condoms sometimes. His HIV screen is negative. Discussion about desire for conception in the future and contraception. She prefers not to start any other contraception besides the condoms that they sometimes use, and does express that she hopes to have a baby within the next couple of years, though they are not actively trying to conceive. So, Chris, maybe if we go ahead and launch the poll. This is what I'd like to ask you. These are the Department of Health and Human Services recommended first-line initial ART regimens. What do you think would be best here? So some things I'm trying to get at here. What's your comfort with dolutegravir for an individual of childbearing potential who may or may not conceive in the near future? What's your choice of NRTI backbone in that setting? And what's your optimal therapy when you don't have the genotype results back yet? So I think this brings up a couple of good points for discussion. I don't think there's one right answer here. This is the real situation. Her insurance would not cover Cabotegravir FTC TAF, so you're choosing between these other options. I've given you a spread there, including dolutegravir plus various combinations of NRTIs. The most recently added option to the guidelines, dolutegravir-rilpivirine, 2-drug initial therapy, which we'll talk about, or the raltegravir-based options. So please go ahead and weigh in, whether you're a prescriber or not. There is no right answer, and That's why I love doing this. So Chris, whenever you feel like we're ready, let's go ahead and share the results. Perfect. Thank you everybody for weighing in. Kind of a spread there, which I think is really interesting. Again, showing there is not one right answer. 29% of our audience today voting for dolutegravir plus FTC TDF. That is what she ended up on for various reasons. But again, I don't think there's one clear right answer. So let's go ahead and talk more about recommendations for initial therapy. First, some basic, but I think important points and reminders. There is a section in the Department of Health and Human Service guidelines about integrating treatment as prevention, or U=U, into our discussions about initial therapy. I think this audience is very familiar with U=U. If you're not, if you're newer to this field, I encourage you to look it up and educate yourself about it. I think an important point here, the guidelines now clearly state that a consistent viral load under 200 copies prevents transmission of HIV to sexual partners. 200 copies is the threshold that was used in the observational studies. The big RCT used less than 400 copies, but really a viral load consistently under that range prevents transmission. And I think it is an important part of our initial counseling and education and can help motivate individuals to adhere to ART. These guidelines state that persons starting ART, such as the individual in the case, should ideally use another form of prevention for at least 6 months and until HIV RNA less than 200 copies. So that may be consistent condom use. It may be PrEP for the partner who does not have HIV, as in the case I presented you, we refer the partner for PrEP, or it may be some other form of prevention. The other key points, and I think again, this is going to be familiar to a lot of you, these guidelines and all the guidelines really now emphasize we should be starting ART immediately or as soon as possible for all the reasons listed here. And the panel supports same-day start. So that could be same day as diagnosis, if that is logistically feasible. It could be first clinic visit, or it really just could be as soon after that first visit as is logistically feasible based on insurance coverage and other factors. So if a person is ready, we do not need to wait for genotype results. We can start as soon as feasible. And if starting that same clinic day is just too much in terms of coordination, I would just say you can start within a few days or as soon as everything is in line and ready. In terms of the recommended options for initial therapy, I'm going to show you first the Department of Health and Human Services list, then the IAS-USA guidelines list, which largely agrees but was updated more recently. You can see here the recommended anchor drugs are all integrase inhibitors, bictegravir, dolutegravir, or raltegravir, with the various NRTI options listed. You can see here there are no NNRTIs on this list of first-line regimens. There's no longer any boosted L-vitegravir because of tolerability and other issues. And you can see here the most recent addition to this list in the last row, the dolutegravir 3TC combination 2-drug therapy, is very reasonable to offer somebody as initial therapy, but there are a lot of caveats to it. You can see there, viral load below 500,000, very importantly, no hepatitis B, and you have the baseline genotype results. So you can confirm that these 2 drugs are both fully active. For all of those reasons, it's not a great option for starting before genotype's back. It, in my experience here in Washington, can be difficult to obtain insurance coverage for it. So for various reasons, it really has not become a go-to at all for me for initial therapy, but I do really like it as potential maintenance therapy after someone starts three drug ART, achieves a suppressed viral load, and then potentially can switch to that for long-term ongoing therapy. The IAS-USA guidelines just updated October 14th, largely agree. You can see subtle differences, no raltegravir listed here, really favoring dolutegravir, bictegravir. That's given slightly higher pill burden of raltegravir and lower barrier to resistance, but these guidelines otherwise largely agree. Now, one interesting point about these guidelines is prior iterations really encouraged TAF over TDF more. And this iteration has stepped back from that a bit and has a little more leeway in terms of choosing TDF and TAF. And I think I would speculate that's largely because of TDF becoming generic and cheaper and more insurance pushback and more difficulty accessing TAF. And then also controversial data on TAF being associated with weight gain, which we will get into. So one thing, just to pause there, and I'd really like to hear from you, how do you choose between TDF and TAF? Feel free, we won't get to question and answer likely till the end, but feel free to put that in there or send me an email. I'd like to know how you choose TDF versus TAF for your adults for HIV treatment. I was sitting thinking about this, and so this is a composite of my opinion and what's in the guidelines. So I was trying to think of strong indications for TAF, and I think if someone has a creatinine clearance below 60, if someone has documented osteopenia or osteoporosis, I would list that as a strong indication. If someone has risk factors for renal disease, risk factors for osteopenia, osteoporosis, I mean, maybe that's diabetes, hypertension, especially if uncontrolled. Maybe that's other risk factors for osteoporosis. Maybe if that is, a creatinine clearance that isn't 60, but is approaching that, I would list that as a, moderate recommendation. I think we could debate about age, but I do think there's good data that individuals who are over 50 are at somewhat higher risk from TDF-induced renal toxicity, especially if there's a booster in the regimen, and I would put that as a relatively moderate indication. One thing also, difficulty swallowing pills, I think we don't often talk about it, but the TAF versions are just plain smaller. The TAF FTC is about half the size of the TDF FTC, so I think that could be an indication for some individuals. And then thinking about, well, what would be the indications to steer towards TDF instead of TAF? I think PEP, I would call that, moderate to strong recommendation. There's very limited data for TAF for post-exposure prophylaxis. One study I know of that used TAF in about 100 individuals for PEP and did well, but that's pretty limited. I think for an individual trying to conceive or in the first trimester of pregnancy, I think again, we could debate that, but if you go by the package insert in the guidelines, there is not yet enough data for TAF for conception or first trimester of pregnancy. We'll get back into that a little more. And then this one, which I'm going to talk about because it is so controversial and such a hot topic, the weight gain issue associated with TAF, the potential for metabolic syndrome, dyslipidemia. I am not convinced that this is an indication that we should be throwing TAF away and using TDF. At best, I think it's a very weak indication, but we'll get more into that. But I'd love to hear from you. How do you choose TAF versus TDF for treatment for your adult patients? Feel free to put that in the question and answer or shoot me an email. Let's do a quick update about dolutegravir and neural tube defects. This is a topic that gave us a lot of concern and really changed our counseling and guidance and decision-making, as of 2 years ago or so, and then has really evolved and shifted, and we've gotten more and more reassurance that this is probably not an issue. So we discussed this last year, but as a brief review, what brought this up as a big question and a big controversy was this observational study from Botswana. They started in 2014 to do surveillance for neural tube defects, largely to look for issues with efavirenz, and then once dolutegravir was rolled out, they continued to do surveillance and look for issues with either drug. And then what we saw in May 2018 was this first interim analysis that estimated the rate of neural tube defects with dolutegravir used at conception at 0.94%, there in the red, compared to 0.12% with non-dolutegravir ART, most of which was efavirenz, and that was statistically different, and that raised a lot of alarm. As the investigators added sites, added patients, added more follow-up time, and got more data, more numbers and more outcomes data, that estimate of neural tube defects from dolutegravir has come down and down and down. As of April 2019, it had come down to 0.3%. So now we're looking at 0.3% with dolutegravir compared to 0.12% with non-dolutegravir. And then the most recent update, which we saw at the AIDS 2020 conference in July, but was from an analysis they did in April. Here in the box, the new most updated estimates are 0.19 with dolutegravir compared to 0.11 with non-dolutegravir, which is no longer statistically significant. So there is no longer a statistically significant difference between dolutegravir and non-dolutegravir ART in terms of neural tube defect risk. So reassuring. As we discussed last year, Botswana is not a country that fortifies its food supply with folate. Very few individuals in this trial, in this study, I should say, were given folate supplementation or were taking folate supplementation at the time of conception. So we have to consider those caveats as well. So I think overall, this is a lot of reassurance. I still think we should counsel, we should be asking individuals about their childbearing desires. We should be talking about contraception. I think that often gets lost in our clinic visits and forgotten. It's a very important discussion, and I think we should be counseling about what we know about dolutegravir risks, but I think this is very reassuring, and we really should emphasize the importance of folate supplementation. Now, one really important point, the perinatal HIV guidelines have not yet been updated to incorporate these most recent findings from that SAPAMO study. So this that I'm showing you from the perinatal guidelines predates that most recent update. These guidelines do clearly now list dolutegravir as a preferred antiretroviral option for pregnant women, irrespective of trimester. So I think that is clear. These guidelines list dolutegravir as an alternative for women who are trying to conceive, but again, not yet updated with those most recent findings. And then, as I mentioned, tenofovir still listed as insufficient data in pregnancy. But I did just show you the reassuring data about dolutegravir, and then I'm not going to review this today for time, but the data is available. We have a review of it on our ECHO YouTube channel. This study called Impact 2010, that's the name of the study, not the year it was done, did show that TAF is safe and potentially preferred over TDF during pregnancy when started after 14 weeks. So only when started second trimester or later. So what we do not have is any data for TAF at the time of conception or first trimester. That's something that's still missing and I hope is coming soon. So I think there's a lot of reassurance for dolutegravir both during pregnancy and at time of conception. I think this is reassuring that TAF started after 14 weeks is very safe, may even be preferred. I think the challenge becomes if an individual wants to conceive or conceives while taking TAF, do we switch it? Should we be encouraging TDF? That's what the package insert would still suggest. And I think that becomes a real one-on-one discussion and involves consideration of the other options, considerations of the risk of a switch. If somebody's tolerating TAF, has a routinely suppressed viral load, that to me becomes really one-on-one individualized decision-making. But I hope to see data for TAF in the first trimester in the relatively near future. Let's do another case. I'm going to show you another poll here in a moment. So another individual from my clinic, this is a gentleman I've known for almost 10 years now, and this is an active ongoing question. So I'd love your input. I do not think there's a right answer, but let me just show you this question that I've been considering. And he comes in every 3 months or so. We talk about this. We haven't made a change yet, but we may soon. So this is a 52-year-old Black gentleman diagnosed with HIV in 2010. Soon after that, he started efavirenz TDF-FTC. So that's the triplet combination pill, which so many individuals started around that time. Around early 2016, we switched him to dolutegravir plus FTC TAF. I felt great about that because he was suffering from depression with the efavirenz. He had low vitamin D. He had elevated triglycerides. He had all the efavirenz issues. I thought switching to the TAF, I thought I'd be, helping prevent any issues with his kidneys or his bones. His CD4 count has been robust. His viral loads are routinely suppressed. You can see his comorbidities, including depression, chronic pain, hypertension, type 2 diabetes, varying degrees of control, obstructive sleep apnea, and elevated BMI, and GERD, for which he takes famotidine. He has excellent adherence, which is to minimize pill burden. And so now, with what's happened over the last year or two, with all the data showing associations between elevated weight gain, elevated BMI, and integrase inhibitors, especially dolutegravir, victegravir, TAF. Here's my question for you. Would you do anything to switch him? And actually, before you weigh in on that, let me show you one graph of his actual weight, just copied and pasted from Epic. And so you can see here on the far left when he started Atripla, you can see the inflection point down at the bottom, which is about when we switched dolutegravir to TAF, and then you can see most recent. But I will acknowledge this is really complicated. This is an individual who, because of a lot of issues, like chronic pain and joint issues, intermittently is able to be active, intermittently adheres to healthy eating. There are a lot of factors that go into these decisions and into weight change. But you can see here the graph. This is what we're using to make the decision. So please go ahead and weigh in. I do not think there's a right answer here. These are some of the options I've been discussing with him and considering. Would you recommend an ART change? Importantly, and I think this comes up not infrequently when considering these sorts of decisions, his insurance, we confirmed, will not cover victegravir FTC TAF, will not cover the combination pill dolutegravir-lamivudine, and will not cover the combination pill dolutegravir-rilpivirine. So if considering those 2 drug maintenance options, we're just gonna have to split it up. We're just have to use it as 2 pills. Not the end of the world, still an option, but that does go into the decision-making. So some options I've given you, some options I've considered myself and discussed with him. And if you would do something different, please put that in the question and answer. I'd like to hear. So would you switch to high-dose Raltegravir plus FTC TAF, switch to dolutegravir plus Rilpivirine, switch to dolutegravir plus lamivudine, switch to dolutegravir plus Doravirine, switch to Doravirine, 3TC TDF combination pill, or hold course, wait for long-acting options coming in the future? Please go ahead and weigh in. Again, no right answer, whether you're a prescriber or not, just what would you lean towards? And Chris, whenever you feel like we're ready, let's go ahead and display that. Okay, again, thank you everybody for weighing in. I love this because, again, I think there's a spread. I think there's no right answer, but very interesting to me, majority in our community today voting for hold course, let's wait for long-acting options. So thank you all for weighing in, and let's talk more about each of these things a little bit. First, I'm going to show you what's been updated very recently in the guidelines, the language around weight change. I'm going to give you a little bit of my interpretation and opinion, and then go into some of the data for these possible switches. So again, thank you, everyone. Okay, both the Department of Health and Human Services and the IAS-USA Guidelines Committee have added language on weight gain to their guidelines. I think it shows how important this is both to individuals with HIV and to providers. And some of this I think is very important for counseling and discussing this topic. So they're very similar in terms of the 2 guidelines, but IAS-USA was updated more recently, so that's what I'm going to show you. So they state that initiation of ART often leads to weight gain. It can lead to obesity among individuals with HIV who start treatment with a normal or elevated baseline weight. When starting ART for someone who is treatment naive, there are certain factors that have consistently been associated with elevated amounts of weight gain. Those factors being a low baseline CD4 count, a high baseline viral load, Black race compared to other races, female sex at birth compared to male sex at birth, integrase inhibitor compared to other anchor drugs in most of the studies, implicating primarily dolutegravir-bictegravir. The data for raltegravir and elbaptegravir more mixed, and then TAF as compared to other NRTIs. Importantly, this guidelines committee wrote, clinical consequences and mechanisms are unknown, and data to date are insufficient to change recommendations for initial ART. Individuals with HIV should be counseled about the potential for weight gain when starting an antiretroviral regimen, and I very much agree with that. Now I'm going to add a little bit more of what I think is important in my interpretation of this data. So I think if you look at some of the most robust studies, like this reference number 1, Paul Sachs and colleagues did this composite of ACTG trials over the years and looked at weight change with treatment initiation. I'd encourage you to look at that. There's some great, very illustrative figures. They found that most individuals with HIV who start ART do gain some weight. It is primarily in the first 12 months, and the median is 2 kilos. So that's somewhere around 5-6 pounds, but there is a pretty wide spectrum. There is a small proportion who gain excess weight. In their study, it was about 17%, so 1 in 5 or 1 of 10 individuals who gain 10% of their body weight or greater. And so it's that small, relatively small proportion, 1 in 5 to 1 in 10 individuals who gain excess weight, who I think are likely at risk, at higher than average risk for developing metabolic syndrome, diabetes, hypertension, potentially cardiovascular disease, fatty liver, other things associated with excess weight gain. But that data is more mixed, more limited, and we don't fully understand the long-term consequences. The other thing we don't fully understand yet is the reversibility if individuals who start certain agents do gain excess weight and then ART is changed. So important outstanding questions there. And then as we discussed last year, some individuals gain weight after switching to TAF or to an integrase strand transfer inhibitor, especially dolutegravir or bictegravir. Again, the median weight change is 2 to 3 kilos. Again, it's mostly in the first 9 months. And I'd like to show you one figure from the OPERA cohort. This was presented again at the AIDS 2020 conference in July. And again, I just think that this image is very illustrative. So what you see here on the Left is average weight. These were all individuals who switched TDF to TAF. And then the three different lines are their anchor drug, which did not change. So this is only a TDF to TAF change. Time 0 in the middle is the time of that NRTI switch TDF to TAF. And then going back 60 months pre-switch and then followed for 48 weeks post-switch. Important things you can see here. So one, if we look at time minus 60 months to time of switch, weight is slowly increasing. I think, as we get older, we all gain weight. We don't like that, but it's true. It happens to all of us. So everyone slowly is gaining weight consistent with the general population, consistent with what's expected with aging. Then if you look at time 0, time of TDF to TAF switch, just after that, there's a pretty sharp inflection point where many individuals gain some degree of weight. And then after about 9 months, it stabilizes again back to sort of standard trends, if you will. So I think this is very illustrative of what we see. Now, what we can make of that, I'm going to get into on the next slide, and I'm going to go out on a limb a bit here and tell you what I suppose is the mechanism, what I suppose is going on here. I might be proven wrong, and that's fine, but I'm going to give you my conjecture. So the million-dollar question here is, what is the mechanism? Is this some new toxicity of TAF? Is this some new toxicity of dolutegravir stimulating appetite and changing various hormonal balances? Or is this some previously underappreciated toxicity of the older drugs? I posit that it's actually the latter, that what we are seeing is, or what we did not fully appreciate was how much the older drugs like TDF or efavirenz suppressed weight. And now when we're pulling those off and switching to newer drugs, individuals gain some weight and then return to their baseline trends. That is my supposition. I'll show you a couple things that lead me to that supposition. So first here, from that same composite of ACTG trial data, you can see on the right, on the top, you can see that there's actually a difference not only between the integrase inhibitors, not only between the NRTIs, but also between rilpivirine and efavirenz. And really, if you look at this study, in every trial of a newer antiretroviral agent compared to the older agent, every single one within the last decade or so, the newer agent has been associated with greater weight gain. So it's not just integrase inhibitors, it's not just TAF, it also exists in the NNRTI class. Now, you could say, well, okay, well, rilpivirine, we encourage people to take it with a meal. Efavirenz, we encourage taking on an empty stomach. Maybe this is related to calorie intake. And I think that is an important caveat. But then if you go back to the advanced trial, which was a trial of treatment initiation done in sub-Saharan Africa, which we reviewed last year, it was pretty clearly shown that those individuals who were slower metabolizers of efavirenz, meaning they had higher efavirenz systemic levels, gained less weight while taking efavirenz, and then when switched to an integrase inhibitor, had a bigger jump up in weight. To me, suggesting that efavirenz, at higher levels of efavirenz, actually were suppressing weight gain in some way. Similarly, if we look at the NRTI class, now bottom right of this graph from the ACTG trials, you can see TAF definitely associated with the most weight, but then there's a spectrum. So TAF followed by abacavir, followed by TDF, followed by zidovudine. Now, I think if you want to know if the issue is TAF or TDF, I think if an individual switched any NRTI to TAF and there was weight gain, that would suggest to me the issue is the TAF. But that's not necessarily what happens. And Grace McComsey and colleagues just presented this, I think, really clever study at ID Week, where they looked at individuals switching TDF to TAF or abacavir to TAF. Again, if the issue were TAF, if it was some new TAF toxicity, I think either switch individual should be associated with weight gain. But actually what they found was TDF to TAF was associated with significantly more likelihood of gaining excess weight than abacavir to TAF. Again, suggesting to me that I think that maybe TDF was doing something we didn't fully appreciate to suppress appetite, maybe mitochondrial toxicity, maybe something else, and maybe that's what we're seeing. In addition, this study called Gemini, which looked at dolutegravir plus FTC TDF as initial therapy or dolutegravir-rilpivirine as initial therapy, I think is very informative, because really what we're looking at here is dolutegravir FTC with TDF or dolutegravir 3TC without the TDF. So really we can just assess what's the TDF effect. And what you can see here is those individuals who got TDF gained less weight. So again, to me, suggesting that maybe the issue is TDF was suppressing weight, maybe it's not TAF, but I think we need to understand this better. Finally, on this topic, because I know this is a mouthful on this, if we look at the PrEP studies, I think it's also very informative. So what I'm showing you here is estimated median annualized weight change using IM injectable cabotegravir for pre-exposure prophylaxis, that's the blue bars, compared to oral FTC TDF, that's the purple bars. So this is individuals without HIV who are at risk for HIV, leaving the treatment realm for a second. But again, I just think this is informative on this topic. You can see on the left, comparing blue, which is cabotegravir, to purple, which is FTC TDF, overall weight change out to 105 weeks, greater with cabotegravir. Okay, well, maybe there's a integrase inhibitor issue here. Maybe there's some toxicity. But importantly, if you break it down by time period and look 0 to 40 weeks, that's when most of the weight difference is seen. You can see here the blue bar 1.54 and the purple bar minus 0.51. So actually the difference here is being driven by weight loss from TDF, not weight gain from the integrase inhibitor, but weight loss from the TDF. And then after 40 weeks, it's all the exact same. So again, a weight differential in the first year or so, largely driven by weight loss from TDF. Similarly, the same group presented cabotegravir compared to placebo and weight gain was the same. So that to me suggests it's not the integrase inhibitor causing the toxicity. Maybe it's the older drugs, the TDF, the NNRTIs, the boosted PIs that led to more weight suppression or appetite suppression than we realized. My big point here being, I am not ready to throw away the integrase inhibitors. I am not ready to throw away TAF. I think we really need to consider these decisions for every individual. And I really think we need to better understand the mechanism here, the long-term consequences before we start switching everybody from integrase inhibitors to older drugs or everyone from TAF to TDF. So this is my way of encouraging us to understand this better before changing guidelines and practice. Okay, so I presented to you a patient who had elevated weight, a lot of cardiovascular risk, diabetes while taking FTC, TAF, dolutegravir, and I gave you a number of options. So let's look at what we know about some of those options that we could consider. So first, looking at this study that enrolled individuals taking TAF-based 3-drug ART and randomized them to either continue that TAF-based 3-drug ART or switch to dolutegravir-rilpivirine. Now, you would think this would be very informative about the weight change issue, because if someone were taking dolutegravir TAF FTC and you just pulled the TAF off, that could give us great detail, great info. Unfortunately, this study does not do that. The reason being, if you look at the baseline regimens, the regimens people were on when they entered, very few, if any, people were taking dolutegravir. So this is the general study design. Again, either switch to 2-drug maintenance therapy, dolutegravir-rilpivirine, which is now approved either for initial therapy or for maintenance ART, compared to TAF-based traditional 3-drug regimens with important inclusion criteria on the left. Again, very importantly, if you're considering 2-drug therapy, the 2 drugs are active and the individual does not have active hepatitis B. Again, at baseline or at enrollment, a majority of individuals here were taking boosted elvitegravir. Very few, if any, were taking dolutegravir. So this really is not what we need. It is not a comparison of dolutegravir FTC TAF to dolutegravir 3TC, but I'll show you the findings because they are informing clinical practice. In this carefully selected population, switching to dolutegravir-rilpivirine was as effective as continuing TAF-based 3-drug ART. Virologic failures were very rare. No new resistance occurred. And the very small number who had a 184V by proviral archive genotype also did fine, but that's 4 patients and I would not advocate for that strategy. And then what we saw at AIDS 2020 in July was some analysis of metabolic outcomes comparing these various regimens. And I'm not going to go through all of this because, again, I think it's limited, but the punchline being there were improvements in lipids and insulin resistance in the group, for the group who switched to dolutegravir-rilpivirine. But again, these were individuals who were primarily switched off a booster, off boosted elvitegravir or a boosted PI. So I think what we can say here is that if an individual is receiving a boosted regimen and they are a good candidate to switch to dolutegravir 3TC, they may see metabolic improvement over time with that switch, but I do not think we know what happens with switching dolutegravir or bictegravir plus 2 NRTIs to dolutegravir-rilpivirine. So that is something that's missing. How about this? Some people voted for a switch for the patient to Doravirine-rilpivirine TDF, also an approved combination pill. A brief review of Doravirine if you haven't prescribed it yet. It is the most recently approved NRTI. It is once daily, unlike etravirine. It has no food requirement, so benefit over rilpivirine. Fewer drug-drug interactions, for example, no PPI interaction, so that's an advantage over rilpivirine. Better lipid effects compared to older NRTIs like efavirenz, and it does retain activity with some, but not all, NRTI resistance-associated mutations. So I think, again, it would be very interesting to look at individuals who are taking other regimens compared to those who are taking Doravirine and look at long-term metabolic outcomes. We just don't have that yet. Here is a study that we have that enrolled individuals with suppressed viral loads, taking more traditional 3-drug therapy and randomized them to either continue that baseline 3-drug therapy, switch immediately to Doravirine TDF3TC, or switch later. Again, I think very limited by the array of regimens individuals were taking at baseline. 70% taking a boosted PI, 25% NRTI, which was mostly efavirenz, and mostly taking TDF. So really what this is a switch study from efavirenz FTC TDF or boosted PI FTC TDF to this Doravirine-based therapy. The switch was effective. And for individuals taking a booster baseline, lipids did improve. Okay, that's something, but I still don't think we know what happens when you switch from an integrase inhibitor to a Doravirine-based therapy. So that is something we are definitely missing. So here's my brief composite of data we are missing and we need to be able to help inform these clinical decisions. So dolutegravir-rilpivirine has not been compared head-to-head in an RCT to TAF-based 3-drug therapy. The studies of dolutegravir-rilpivirine were all compared to TDF-based therapy. Again, I mentioned this, I do not think we know what happens with a switch to dolutegravir-rilpivirine compared to dolutegravir-bictegravir with 2 NRTIs. We have 0 comparisons of Doravirine to integrase-based therapy. Either the initial studies or switch studies of Doravirine did not include integrase inhibitor comparisons. I think that is a huge, huge gap in the field. And we don't really have any data for switching dolutegravir to 2-drug therapy with dolutegravir plus Doravirine, even though in theory that has a lot of benefits and we are using that in some cases. Now, one really important thing that's coming that I think is going to give us valuable information is this ACTG trial called 5391 or DO IT, which is going to enroll individuals who have experienced substantial weight gain, more than 10% of body weight, while taking an integrase inhibitor plus NRTIs, and is going to randomize them to either continue their baseline integrase inhibitor-based regimen or switch to Doravirine plus TDF-FTC or Doravirine plus TAF-FTC. I think this will give us very valuable data, so please think about patients in your clinic who may meet these criteria. I think it's BMI above 27.5 and more than 10% body weight gain while taking integrase inhibitors, some other exclusion and inclusion criteria, and we will alert you about that. And if you think of patients in your clinic who would be candidates for the study, please talk to Rachel or Katrina or Chris or any of the ACTG trial or myself, and look out for more info coming hopefully within the next couple months on that one. Another option, so a lot of votes here for waiting for long-term therapy. So let's talk for a moment about long-term therapy. This, I think, is right around the corner. The combination injectable intramuscular Cabotegravir-Rilpivirine, approved in Canada in March, so currently available in Canada, not yet approved here, but I suspect we will see it approved first quarter 2021, so coming right around the corner. This is a summary of the RCTs of this combination long-acting injectable therapy. This is a combination of an integrase inhibitor and an NNRTI. Importantly, neither agent has a high barrier to resistance, and I think that's important to keep in mind. So I'm sure we'll be talking a lot more about this once it is approved. I'm not going to go through all these studies. I'm going to show you some data from this one called Atlas, because I think it is the most applicable to the patient I showed you. And then I'll talk a little more about this before we wrap up on other topics. So this was a randomized phase 3 trial that enrolled individuals who had suppressed viral load with other important inclusion criteria, which you can see on the left, and randomized them to either continue their effective 3-drug oral ART or take daily oral Cabotegravir-Rilpivirine for 4 weeks to make sure they tolerated it, maintain a suppressed viral load, and then switch to every 4-week injectable Cabotegravir-Rilpivirine. Importantly, again, the baseline regimens here were mostly efavirenz and boosted elbictegravir, mostly with TDF. You have to dig into the supplemental material here on this one to figure out the baseline regimens, but that's what most people were taking at baseline. Importantly, the IM Cabotegravir-Rilpivirine monthly was as effective as 3-drug oral ART. Injection site reactions were common, but really not treatment limiting, which is important. And then weight, again, the hot topic everyone wants to know about. At 48 weeks, median weight gain was 1.8 kilos with long-acting ART and 0.3 kilos in the oral ART group. Again, most of which was TDF, NNRTI based or TDF boosted PI based. Again, I think maybe suggesting the integrase inhibitor is not the issue here. So my reflections and questions for you to think about with long-acting Cabotegravir-Rilpivirine. So it does seem to be an excellent option for carefully selected individuals. Like other 2-drug regimens, we need to be very cautious that when switching an individual to this, once it's approved, of course, both drugs are active, individuals are likely to adhere. We do everything we can to support adherence, and a person does not have hepatitis B. This could be a great option for individuals struggling with pill fatigue, struggling with the stigma of having those bottles of pills at home. It's been suggested that maybe it'll help with care transitions out of the hospital, out of the correction system. I think the optimal use of this is to be determined. These are some of the operational and clinical questions that I think we must consider. These are all injections to be given IM in the glutes in clinic. So there's a question about burden to staff. Whether the approval will be every 1 or 2 month dosing is to be seen. In Canada, it's approved only for every 1 month dosing. The IAS-USA guidelines update last month suggested every 2 months might be appropriate for individuals who are very likely to adhere. I don't think we fully understand if there's any added risk to every 2 month dosing compared to every 1 month. There was a study of that, which I'm not going to go through today, but I don't think we fully understand that. The optimal oral lead-in, the optimal bridge with oral ART for any missed doses of the injectable or oral tail if somebody is stopping or loses access to it, I think is to be determined. The role for individuals with imperfect adherence or detectable viral load, and there is an ongoing study that teams here have been a part of looking at that. Will individuals develop injection site reaction fatigue over time? What are the benefits? Again, long-term metabolic and cardiovascular benefits, and of course, cost and access, always the huge, huge question. Now, again, this is not approved here yet. It is mentioned in the IAS-USA guidelines. It is coming soon, but I just wanted to pull up the package insert from Canada to see if it helps answer these questions, what's being done there. Here's just an example, again, not approved in the US, but what's being done in Canada. It's a 1 month lead-in of the oral versions, and then a slightly higher dose, which you can see there in the middle, and then monthly doses at a slightly lower dose. But then if you look at what happens with missed doses, I just show this as an example of some of the clinical decision-making that's coming with this long-acting therapy. There is a window where an individual can still get their injection if they're within 7 days of the planned time of when they should get it. But then there's important decision-making based on whether it's more than 7 days, whether it's been more than 2 months or not. So I think we're really going to have to see how the FDA outlines suggestions for management of both the lead-in, missed doses, and if a person is stopping. So very exciting that this is coming. It's going to be revolutionary, the first long-acting injectable therapy for HIV treatment, likely also for PrEP, but some outstanding clinical and operational questions. Now, there are a couple of other long-acting options we could wait for. Again, a lot of people voted for the patient I showed you to just hold course and wait because there are exciting things coming. So another thing we could wait for would be Islatravir plus Doravirine. Not coming quite as soon, but an option we could see here within the next 1 to 2 years. So Islatravir, I mentioned this last year, it has a novel mechanism of action. It is an NRTTI, or nucleoside reverse transcriptase translocation inhibitor. Important point there being it does inhibit reverse transcriptase like the NRTIs, but in different mechanisms and multiple mechanisms, and it does have a lot of potential advantages. It seems to be active in the setting of pre-existing NRTI resistance. It seems to have a very high barrier to resistance itself. It seems very potent and effective even at low doses, and has a long half-life, which I think gives it some exciting potential, such as possible oral dosing only at once a week, or maybe less frequent, like once a month. And then what's being explored is implants, for example, for PrEP that could be applied just once a year. So some very exciting potential around this drug. I think the other thing that's been discussed is it seems like in combination with Doravirine, this would be a pretty metabolically and weight neutral combination. Again, I don't think we fully understand all that goes into that, but that is the theory. And this study, which we saw at CROI last spring, looked at that. So these were individuals, who were treatment naive, they were enrolled, they were randomized to either Doravirine 3-DC TDF or 3-drug therapy with Islatravir at varying doses, Doravirine plus amivudine. And then if they did well on that combo and suppressed their viral load, then transition to Islatravir, Doravirine, 2-drug maintenance therapy. The punchline is, you can look at this more if you want to see details. The punchline is both options seem to be pretty weight and metabolically neutral, comparing Doravirine 3-DC TDF to Islatravir Doravirine. But again, I think we need longer term follow-up data, and I think this is limited because there are no comparisons to TAF and no comparisons to integrase inhibitors. So that is my mouthful on what is coming and on the weight change issue, which is such a hot topic. And hopefully as the next year or two goes on and we get more and more RCT studies like the ACTG trial, we will understand better the mechanism of the weight change, the long-term consequences, and the potential reversibility. So stay tuned for that. And hopefully in the next year or two, we'll have better guidance for what to do if an individual has gained excess weight on specific ARV regimens. That I just do not think we have yet. But finally, let me wrap up by reviewing the newest options, the latest approved options for salvage ART, and then we'll have time for questions and discussion. Again, I'd love to hear what you think, how you choose between TDF and TAF in your practice for adult HIV treatment, and then what you think about the weight change metabolic syndrome issue and whether you're changing regimens because of that issue or not. But salvage therapy. So no Zoom poll here, just a question to consider. Focusing on Fostemsavir, the most recently approved salvage drug. If you're not very familiar with that, hopefully this will add a bit of familiarity. And if you are more familiar, just a question to consider. So, and thank you to Dave Hatchie for sharing this case in some of these slides. So this is a 57-year-old Caucasian man, 30-year-old history of HIV, complicated by neuropathy, lipodystrophy, chronic diarrhea, a chronic reduced renal function with an estimated creatinine clearance of 45, significant multi-class resistance, including NRTI, NNRTI, and integrase, tropism assay or trophile dual mixed, and you can see a medication list there. So just the question to ponder, would Fostemsavir be an option for this individual? Let's talk a little bit about Fostemsavir, and then I'll tell you what I think is the answer. So Fostemsavir is a prodrug. It is metabolized to Temsavir, the active drug. This picture here from David Spock. Thank you very much, David. No one makes these graphs quite like David, and this is so useful. So the Temsavir is depicted by the blue boxes, and you can see here the HIV GP120 coming into the CD4 T cell to bind to the CD4 receptor in green. You can see that the Temsavir in the blue box binds to GP120 adjacent to the CD4 receptor binding site, and that prevents any conformational changes of GP120 so that it cannot attach. So Fostemsavir is a brand new class described as an attachment inhibitor. Just going to compare that to the other relatively new salvage drug, ibalizumab. You can see here, again, this illustration from David Spock, you can see here ibalizumab depicted by the upside down Y shape here, binding not to GP120, but binding to domain 2 of the CD4 receptor. Domain 1 is where the CD4 receptor binds to GP120, but binding to domain 2 here, preventing any shifts that should occur after attachment and thus blocking any interaction with the co-receptor to block cell entry. So that's why ibalizumab is referred to as a post-attachment inhibitor, Fostemsavir as an attachment inhibitor. But again, importantly, these are two relatively new salvage drugs that could be an option for those individuals who just have lost all other classes. Importantly, Fostemsavir is an oral drug given twice a day, whereas ibalizumab is an IV infusion given every 2 weeks. For those reasons, I think if one can give Fostemsavir plus at least one other active drug and an optimized background regimen, that would be preferred over the ibalizumab, but there are individuals who need this drug. Back to Fostemsavir, some key take-home points. It is, again, an option for heavily ART treatment experience with few other options. It blocks attachment, as I described. Both of the drugs I mentioned, Fostemsavir and ibalizumab, work regardless of tropism status, regardless of whether somebody is R4, X4 tropic, so that is an advantage over Maraviroc. Fostemsavir is oral twice a day, few drug interactions, but not zero. For example, rifampin and other strong CYP3A4 inducers are contraindicated. It does appear to be safe in renal impairment and hemodialysis. Levels may increase with hepatic impairment, but we do not really know how clinically significant that is or what we should do if a person with hepatic impairment needs the drug. And the answer is yes. I think for the patient I shared with you, Fostemsavir would be an option. So I think we're at, what time are we at? Oh, we're at 8:51, perfect. So I think we have 9 or 10 minutes. Would love to hear questions or discussion, your thoughts on what you do clinically or how you manage things differently. Would love to hear your experience and comments or any questions I am happy to field.
Thank you so much, Brian, for that excellent talk. I just wanted, there's a number of questions and I'll let you and Amber get to those. But I just wanted to highlight how even though there's a lot of data that you present and clear recommendations, there's a lot of art in the practice of HIV care that you've highlighted with all the different options that we have. And so thank you very much for highlighting all the data.
Thank you, Shrisha.
All right, thank you, Dr. Wood. Taking us back to the first case for our first question, the 30-year-old Latina, intermittent condom use, interested in conception. Would you still do genotype for this case?
Yeah, thank you so much for that question. And I think that gets at a question that has been raised in recent years. Do we need to do baseline genotypes? And as a corollary, should that baseline genotype include integrase or not? I think you could argue that we could get away from baseline genotypes for everyone because transmitted integrase resistance is so rare, and because for the vast majority of individuals, we're starting integrase inhibitors that have a very high barrier to resistance, mainly dolutegravir or bictegravir. That said, what's in the guidelines, and I think what is recommended and still makes a lot of sense, is to go ahead and get that baseline genotype because that's an opportunity to document if anything's been transmitted and if there is any significant NRTI resistance that could affect your choice of therapy later on. For example, when switching to maintenance therapy. Also from a public health standpoint, it's very important for contact tracing. So a baseline genotype for everyone, I still do. I still think it should be routine. I still think it's important. I do not do a baseline integrase genotype unless there is a extenuating factor. I suspect the person contracted integrase resistance or could have contracted integrase resistance for some reason, and that also is supported by the data and guidelines. The most important point here, I think, is that even though we send a genotype on everyone at baseline, we do not wait for the results to start ART, particularly if an individual can receive a drug like dolutegravir or bictegravir, particularly if a person can receive a drug like dolutegravir or bictegravir. Thank you for the question.
All right, taking us to the second case, the 52-year-old African-American man, various comorbidities. For this fellow, are you counseling him regarding his diet or are you working with his DM specialists?
Absolutely. So thank you for highlighting that. And again, what that brings me back to is these conversations around weight and metabolic and cardiovascular risks. I think it's really a lot of what we do in HIV practice these days, but they are complicated and there are a lot of factors. So I think that we do not fully understand the associations with ART, the mechanism, or what happens with switching ART. I think we need to learn more about that. I think we need to counsel everyone about the potential for weight change with starting ART or with an ART switch. However, to your question, we cannot forget all the other important measures. So for everyone, along with that counseling, I'm encouraging healthy eating, I'm encouraging being active and lifestyle modifications and referring to our nutritionist. So we cannot stop those measures to help support the individuals as well. So absolutely working with him on nutrition, on activity level, working on him in all of our more traditional avenues on our diabetes. So thank you very much for that very important reminder.
All right, another viewer asks, we are focusing so much on weight and weight gain, but what about any data around actual clinically meaningful side effects like cardiovascular outcomes?
Yeah, thank you very much for that question. $1 million question. And I think that that is just what is, that data we just don't have yet to the point that we need it. There's some more preliminary data that is rather mixed about risks of things like diabetes and hypertension, especially in that first year after starting or switching ART. I think there is suggestion that individuals who gain excess weight, yes, are at higher risk of metabolic syndrome, diabetes, hypertension, but I have not seen anything about long-term cardiovascular risk. And so we really need that and just don't have it yet. I have not seen anything about long-term risk of other complications of excess weight, like NAFLD, fatty liver, which we see a lot anyway. Cognitive impairment, has been associated with elevated BMI and with excess weight. I haven't seen anything about long-term consequences in terms of cognitive impairment. So your question and point are so well taken. We need that data, and part of the reason we're not focusing on it yet is we just don't have it to date, but I hope that it's coming in the future.
All right, time for just a couple more. When do you estimate that Islatravir will be available?
Oh, good question. I have not seen anything exact. It is not at the point of submission to the FDA yet. My very general estimate, given it's in phase 3, would be 1 to 2 years, but that's a more rough estimate.
All right, any data for IM Cabotegravir-Rilpivirine in people with advanced kidney disease?
That is a great question. Not yet, I believe, is the correct answer. In theory, both agents should be fine with reduced kidney function if we extrapolate from other integrase inhibitors and if we extrapolate from what we know about oral rilpivirine. But in the clinical trials, they have enrolled only individuals with healthy kidneys, and I've not seen any data for those drugs in advanced renal impairment yet, but I imagine that is coming and potentially even being done. And if anyone knows better than that, please put it in the chat box.
All right, last question. What does the do you prefer TAF to TDF in patients on LICO3?
I missed the last part of that, Amber. And patients on?
On LICO3?
Lithium, I think.
Oh, on lithium. I cannot say that that has come up for me in clinic or that I have a strong opinion on that. I will just say, and I'm not an expert in lithium use, but I will say that I know lithium raises risk of various renal complications. So if it's a person in whom you're worried about the kidneys and worried about side effects of lithium, that would steer me towards TAF if you can access it. And I would probably make an argument for TAF in that setting. If you cannot access TAF for any reason and are using TDF, I would monitor renal function very closely.
All right, that wraps up our Q&A. Thank you so much, Dr. Wood.
Thanks, everyone.